ANCA Associated Vasculitis, AAV. Overview and classification. AAV encompasses a group of autoimmune diseases marked by small blood vessel inflammation. It is divided into three subtypes. 1. Granulomatosis with polyangiitis, GPA, features granulomas and systemic involvement. 2. Microscopic polyangiitis, MPA, distinguished by necrotizing vasculitis without granulomas. 3. Eosinophilic granulomatosis with polyangiitis, eGPA, characterized by asthma, eosinophilia, and vasculitis, often with cardiac involvement in MPO-negative cases. These conditions are linked to anti-neutrophil cytoplasmic antibodies, ANCAs, targeting PR3 or MPO, which activate neutrophils, triggering inflammation and tissue injury. Pathogenesis. The disease mechanism involves loss of immune tolerance to PR3 and MPO antigens. ANCA antibodies activating neutrophils, releasing inflammatory mediators, and forming neutrophil extracellular traps, NETs. Damage primarily affects the kidneys, lungs, and other small vessels. Complement activation, particularly the C5a, C5aR axis, exacerbates tissue damage. Clinical features. AAV symptoms are variable and can affect multiple organs. ENT, chronic rhinitis, sinusitis, epistaxis. Respiratory, cough, hemoptysis, cavitating lung nodules. Renal, rapidly progressive glomerulonephritis or RPGN. Skin, purpuric rashes. Neurological, peripheral neuropathy, mononeuritis multiplex. eGPA specific, asthma and eosinophilic infiltrates. Diagnosis 1, ANCA testing. 2F and ELISA are commonly used to detect CANCAR3 or PANCMPO. ANCAs can also be present in infections, drug reactions, or autoimmune diseases, making testing alone insufficient. 2. Biopsy, essential for confirmation and subtype differentiation. GPA, granulomas. EGA, eosinophilic infiltrates. Autoimmune necrotizing vasculitis. 3. Monitoring tools. BVAS, Birmingham Vasculitis Activity Score, measures active disease. VDI, Vasculitis Damage Index, assesses long-term organ damage. Treatment approaches. Induction therapy. For active and severe cases, GPA-MPA, cyclophosphamide, CYC, or Rituximab, RTX, combined with high-dose glucocorticoids. RTX is preferred for relapsing disease due to its safety profile. eGPA, high-dose glucocorticoids as the first-line treatment. Mepolizumab, IL-5 inhibitor, is effective for steroid sparing in refractory cases. Maintenance therapy. Rituximab, superior for relapse prevention compared to azathioprine, AZA. Methotrexate, MTX, effective for less severe cases but has higher relapse rates. Mepolizumab reduces relapses and allows glucocorticoid tapering in eGPA. Key clinical trials. 1. RAVE trial showed that rituximab is non-inferior to cyclophosphamide for remission induction in GPA-MPA. PEX trial demonstrated that low-dose glucocorticoids reduce infection risks without compromising efficacy. Plasma exchange flex showed no added benefit. 3. MIRA trial highlighted mepolizumab's efficacy in reducing relapses and steroid use in eGPA patients. 4. MAIN-RETSIN trial reinforced the role of rituximab over azathioprine for long-term remission maintenance. Prognosis. The 5-year survival rate for AAV is approximately 70 to 80%. Poor prognostic factors include advanced age, renal insufficiency, cardiac involvement. Guidelines. The EULAR 2023 recommendations emphasize individualized treatment based on disease severity, ANCA subtype, and prognosis. Long-term therapy, extending beyond 2 years, is advised for relapse prevention, particularly in high-risk patients.